Assalamu alaikum, everybody, and good afternoon. Thank you for being here, and thanks for the invitation for the organizer. I enjoyed the previous presentation, Dr. Anas. It was excellent. I learned a lot, and I impressed myself that I got the answers right, at least the first two. I learned from it. Thank you. So now we'll switch gears and talk more about a different, topic about nephrology. Common scenarios. I was talking about pick a common topic in nephrology, and we together picked hematuria, or discoloration of urine. Very common presentation of kids coming to pediatricians or GPs, and when should we be scared, what should we be asking about, when should we advance, when should we refer those patients to a nephrologist, and so on. So I'll make it very quick. First, for me, I will start first with some cases, kind of just to trigger your thinking. So the objectives of my talk will be to be able to hopefully make you able to define and recognize hematuria in a child, to be able to generate a differential diagnosis when you see those kids. What are more common, what are the serious causes of hematuria, if there is? Thank you. And to have a clinical approach to hematuria, kind of more of a way to draw a scheme for you to know how you approach those kids. So we'll proceed to the cases. First case is 12-year-old boy who presenting with a red urine since the night before. He's otherwise healthy. Family panicked when they saw the discoloration of the urine. Most parents panic for having a discolored urine. We checked his blood pressure, got the history. There's nothing really remarkable other than the discoloration of the urine. You looked for fluid overload, hypertension, things you thought of can be related with the kidney problem, and nothing was there. So what would be your next step as investigation? So in the history, nothing was really remarkable, painless, hematuria. You did your urine dipstick, right, in the office, which I encourage most pediatrician or all pediatrician to have a urine dipstick. It's a very valuable tool. It's easier. You get the result instantly instead of sending it to the lab, waiting for the result and so on. And then urine dipstick was totally negative. You go back to your history and ask if the patient took any medication, any food, anything would discolor the urine. Actually, I put this case just to always keep in your mind thinking outside the frame. Don't only, discolored urine doesn't always mean blood, okay? It can be as simple as taking different foods, right? Berries and so on, or medication which can discolor the urine, which the family wouldn't, or the child wouldn't care to tell you because they didn't think it's related. So the urine dipstick will give you a lot of information, not only the blood. Febrile child, right, coming, we see a leukocyte esterase and nitrate positive. That goes more with the UTI, right, along with hematuria. Or having a totally clean, even negative, urine dipstick means nothing really remarkable there. That's more of reassure you. You then proceed of sending your urine analysis. But at least you will get a first reassurance sign, either for the family or for yourself, not to proceed further with doing extensive blood tests and so on for those patients. So again, I kind of list here, it's easy to find those list of what other causes of red color urine, right? Drugs, foods, metabolites even can cause it. If it come with a congestion, would come different case. A child came with pallor and hematuria, then a different story, right? So you should put things together all the time, but think outside the box. Don't limit yourself only this colored urine mean there is blood in the urine. Second case, again thinking outside the box. 5-year-old present with pallor, shortness of breath, sudden onset, okay? Or let's say in the last 24 hours. You did urine specific gravity, normal, heme was 2+, protein was negative. You proceed with the urine analysis because the family is telling you urine is a bit darker, but not sure if it is really red. And then, again, there were no RBCs in those urine. So what do you think about this case? Hemolysis, right? So you did the CBC and his hemoglobin is 5. White cell count was, hemoglobin was 8, white cell count was 5, and the platelets 180. Retics was high, and here you go, hemolytic anemia. Then you will proceed with digging for the reason of the hemolytic anemia, which can be, again, a different chapter. So the first two cases of more of think outside the box. Don't limit yourself. Red color urine mean kidney problem. Okay, always think of other possibility or other reason causing this red discoloration or discoloration of the urine, regardless, can be red, brown, just dark yellow. Third case, 14-year-old girl, she's healthy. She came to your regular checkup. You did a urine. Specific gravity was bit high, 1.035. Heme was +2 on dipstick and protein was trace. You proceeded with sending urine analysis for this patient, and then the red blood cell was 5 to 10, kind of on a bit on the just above the borderline, and then white cell count was 0 to 5. No urinary complaint, healthy child. This urine was collected at the end of the day because the child was, or the girl, the teenager, let's say, was forced by her mom to go for the doctor checkup at the end of the day. She's an athletic child who doesn't drink much of water. You repeated the urine after you reviewed your history, of course, examined the child, nothing remarkable was there. You encouraged more fluid intake, repeated the urine, specific gravity dropped to normal, and RBCs are done. So always remember, before you label a child with a hematuria, microscopic hematuria, you need 2 out of 3 samples to be persistent microscopic hematuria, mean more than 5 blood cells on a sediment of a centrifugated urine with a normal specific gravity. Okay, so remember this definition before you proceed and label kids with microscopic hematuria or persistent microscopic hematuria and going in and investigating them. Fourth case, 9-year-old girl presenting with fever, rash, coryza, conjunctivitis, and dark urine. I kind of more train my brain. If I have more than one system affected in a child, it's either viral or systematic or autoimmune, right? Goes with those two kind of common things. So what do you think about this case? Any suggestions? Sorry? Glomerular nephritis, others would think? Might be still viral, right? She's at that age of it might be glomerular nephritis, might be vasculitis kind of thing, right? She came with coryza, but the fever part with the coryza and conjunctivitis will throw you more of the viral kind of direction for those patients. You did, and they were RBC were there. Some also rotation of the bladder is there. So there's something going on in this child. It's not a straightforward kind of a glomerular nephritis picture. And then here your answer. You got adenovirus in the urine. It's not common to be seen, but the presentation is typical for those patients. So again, think about it, thinking outside the box for those kids. Fifth case, 14-year-old girl present with textbook, right? Intermittent, sudden onset left flank pain, and dark urine. You did urine, specific gravity was normal, heme was 3+, protein was negative. Urine analysis, red cell was there, no white blood cell, and so there were no fever, right? But she came with flank pain and dark color urine. It's like stones unless proven otherwise. This we see more, or I see, I'm sure you as a pediatrician, we see a lot of, much more of stones nowadays in kids with a younger age. Stones was more of an adult's kind of, but now with the change of the fluid and the diet and so on, and our kind of new cultures and eating cultures and habits, the kidney stones had been more in the community. I'm seeing a lot of patients with kidney stones. Forgetting the genetics ones like primary hyperoxaluria and so on, there's other kind of even oxalates or the calcium stones and uric acid stone. So there is, if you get crystals, not all labs will report that, but if your lab report it or encourage them to do that, will help you to guide in diagnosing those patients with stones early on and then prevent it. Because if you have it as a child, because of different habit or your body excretion or your body metabolism, adjusting things from the beginning would first prevent or reduce the chances of kidney stone. Or if it is an inherited like primary hyperoxaluria, diagnose early, and then early intervention would maybe delay renal failure. So we have different kind of stones. Unfortunately, the pointer, I was told, doesn't really, yeah, it doesn't work on the screen, unfortunately. So you have the calcium oxalate stone, one top on the left, the common ones, which you see in this age group. Uric acid stone also is common. The sorbate stone, you see it mainly with infections in those kids, and cystine crystals, usually it come, so it depends on the age of the child, you kind of group them if they are too young or they are older kids. The older kids, you would think of cystinuria, and usually most likely you get a positive family history of a parent or a sibling or somebody close relative with a recurrent kidney stones who required a lot of lithotripsy and so on. Fifth case, the same one. So this is kind of the workup which you will send. You will start with sending urine calcium creatinine ratio, and remember there is a different reference range, a normal range according to the age of the child. So the younger the child, the higher the expected normal ratio of calcium creatinine. So it's not one ratio labels all, it's easy accessible. Online you can search for calcium creatinine ratio for different age groups. You will also look at the citrate, you look at the oxalate, uric acid, and cystine. Especially the serious one among all of this is the oxalate. So if you see a child who is coming with hematuria, 7 months old, right? Not common. This child was referred to you or landed up in your clinic. You did an ultrasound and a urine. There's RBC in the urine. Kidney function was normal for this child. Ultrasound showed small stones, bilateral or unilateral. And then you did part of your workup, the oxalate, and it was high. Think of primary hyperoxaluria on those kids. Send serum oxalate, and then to confirm, to do genetics test. That's a disease which will lead to renal failure. So one of the serious one shouldn't be missed. We have few cases in the last, I say 10 years, I've seen 2 cases which was missed and land up in our hospital with end-stage renal disease on dialysis. Most on those patients anyway, nothing could have been prevented to prevent that, reaching that stage of end-stage renal disease. But speaking now, but there is now in the field a new gene therapy, but still not really approved to be used in kids, that will prevent this from happening. But right now, those patients, the family would have been aware of it earlier. A liver transplant would have avoided the patient to go into this stage renal disease. Last case is a 14-year-old girl who is hypertensive, had left knee arthritis, dark urine, and manna rash. Textbook lupus, right? Urine dipstick was normal, hemoglobin was 2+, protein was 2+. You did a urine analysis, there is microscopic hematuria, and there is red blood cell cast. Red blood cell cast is always pathological, okay? It's always pathological, again I'm repeating, because it reflects that there is a glomerulonephritis. This child is hypertensive. If you do a renal function, it might be deranged or not, or normal. And then you will proceed with working up this child. This is a child who have, again, remember, multi-organ affected. Think of vasculitis. The older the child, the higher the chances of vasculitis. So this kind of textbook, not all patients will come this way to you, right? We had a patient, a male, who was 11-year-old at the time he presented with prolonged low-grade fever, several hospitals, and then with severe headache, okay, to a private hospital in Dubai. And then we were called because they found that he had nephrotic deranged proteinuria and microscopic hematuria. And then he was CNS vasculitis proven by MRI. So not all patients will come as a textbook. You have to think globally. The more the systems affected in the patient, the more you are leaning toward vasculitis, especially in the patient who are lingering with other physician and then end up seeing you with a multi-system affected. So this is the typical red blood cell cast and how it will appear. So when the urine and the sediment goes into renal tubule, there are several reasons or several casts can form inside your urine. The important one are the red blood cell cast and white blood cell cast. Other
can be found, but usually related to different reasons, dehydration, or even acute tubular necrosis. If you see an eosinophil cast, which is not very commonly, and most labs won't report it because it's not easy to pick in labs, and most labs won't report it. But if you see an eosinophilic cast, to be more specific, it's more specific to interstitial nephritis. So those kids who come to you, you give them antibiotics, or they're taking non-steroidal for other reason, suddenly come with increasing in creatinine, this hematuria, either gross or microscopic hematuria, hypertension, might develop even nephrotic range proteinuria, was more of interstitial nephritis. Those patients, if you treat the offending agent or remove it from their treatment, usually they improve with time. With very small percentage will require some steroid to help them overcome that. So the same patient, we sent complements, and then the workup for lupus, and you got your answer. So I'll come now for a few slides just to recap what we said more in a systematic way, okay? So hopefully the cases kind of trigger your thinking, and now when you go systematic, you kind of fit it to the cases we just went through. So again, just to recap the definition of hematuria, you have to have more than 5 red blood cells in a sediment of centrifugated urine. Child should not be dehydrated, which you can be reflected by your normal specific gravity of the urine. So train your brain to look at specific gravity and to know, and then with time you know that this is higher, this is not normal, this is more concentrated urine. Let me just hydrate the child and repeat my urine. And you have to have 2 out of 3, or maybe the 3 of them, at least 2 out of 3 in, let's say, 2 weeks' time. That's talking about child who's healthy looking. But if your child coming on edematous and hypertensive or having some renal impairment, then you don't need to wait that long, right? Because you have other markers in your urine reflecting, or in your blood, reflecting that the child is not just a benign microscopic hematuria. So 3 vital questions to ask yourself when you see this patient at the beginning. Is it hematuria? Remember the first 2 cases, think outside the box. And then, is it serious? Is it urgent? And that will come from your history and your examination, even if you before you step to your investigation. So if your child is hypertensive, your child is puffy, your child is irritable, right? In HUS kids, for example, infants usually very irritable. And is there a family history of, or in the patient personal history, rash, joint pain, or arthritis overall? Is there different rashes, right? We'll come to a few pictures for the rashes and what can be related to those. So your history is vital. Family history will add up to things. And then your examination, then you proceed with your investigation to categorize your patient if it is serious or non-serious. And then you will go to the cause, but you will be more specific in what you investigate, because you will be then guided or limited, or as I always tell my resident and my ex-residents, by you taking your history, you rule in and you rule out your diagnosis. So, and part of the seriousness, you need to categorize your patient. Is it a nephritis or is it a nephrosis? And those points will help you define your patient or classify your patient, right? In a nephritis, you will have hematuria, microscopic or gross. You will have hypertension. You will have oliguria on history. Not everybody will pay attention, especially if you get a teenager. The answer is always, I don't know, right? And increase creatinine. Or sometimes, again, here, and we don't have always this privilege of having a previous renal function for those kids, right? Oh, really? Only? Okay. And then in nephrosis, you will have edema, because those patients will have nephrotic range proteinuria, will have low albumin, and will have hypercholesterolemia. Plus, will have the hematuria. So that will lean toward more of something more, again, more serious for those patients. Remember that all those patients can go into rapidly progressive glomerulitis, which is kind of the nightmare for us as nephrologists, because those patients, if they come progressively to renal failure, then you will be faced with a child might end up with even end-stage renal disease if you don't intervene early. And this is kind of there's no pointer. So the glomeruli on the left side is a normal glomeruli with a normal cellularity, and then here with the mesenteric hypercellularity. This might progress to fibrosis, crescent and fibrosis, and then you lose your glomeruli one by one, and then you end up with chronic damage for those kids, which we always keen and jump on those patients. That's a light microscopy, but we do immunofluorescent for all patients who we biopsy, just to align the patient to a diagnosis. So rapid glomerular nephritis, RBGN, goes under immune complex, immune, and anti-GBM. So in an immune complex, the common one which you will see is post-infectious glomerulonephritis, and then comes down the IgA nephropathy, lupus, and HSP. And autoimmune, less common to be seen in patient. Anti-GBM, again, is not very common, but we do have cases. And usually those cases progress fast to end-stage renal disease, require plasma exchange, and other strong immunosuppressants. In those patients, so in the first one, the post-infectious GN, you will do your ASO titer. If you think lupus, you will do anti-DNase for the post-infectious. You will do your immunoglobulin for IgA nephropathy, your lupus, again, you know the track. And the complements is always a good thing to define things for you or help you to align kind of diagnoses for those patients. And autoimmune, your ANCAs will help you, and then most of those patients will go into biopsy, except the post-infectious GN and a normal kidney function IgA nephropathy child with non-nephrotic range proteinuria. Those patients, the two categories, which is the commonest you see in patients with hematuria. The common one is post-infectious GN, which is very benign. Okay, those patients will have a history of, you know, the textbook kind of pharyngitis or skin infection. You will not always get it in 100% of patients. But then you will prove it by giving high ASO titer, low C3. C4 can be low in some patients, but those patients, keep an eye on them. So keep an eye on your complement. If it is even only C3 low, it should normalize within 8 to 12 weeks. If it is still not normalized, and the patient is still having proteinuria, and especially if it's nephrotic range proteinuria, you have to proceed with biopsying those patients, or referring to nephrologist for a biopsy. And then, because they might be an MBGN, not just a straightforward post-infectious GN. In those patients in post-GN, most likely your management is supportive. Just because of the sake of time, I won't go through the details of that. Those patients, there's on a 137 cohort done by Vogt et al., published by him, none of them went into end-stage renal disease, and high creatinine was detected in 10% of patients, was referred back with no immunosuppressant treatment. IgA nephropathy, usually the typical presentation is intermittent gross hematuria, happened during colds. They might come with a microscopic hematuria, not necessarily always you will get a gross hematuria in a child with IgA nephropathy. They can come with nephritis, they can come with nephrotic syndrome, or even end-stage renal disease. It's not a benign disease. Around 30% or so of patients might develop end-stage renal disease, or go into renal failure, not necessarily end-stage renal disease, and might require immunosuppressant. So not all IgA should be reassured that that's okay and nothing is going to happen for the child. The common kind of IgA nephropathy we see is the HSP, or you see as a pediatrician is HSP, right? HSP is not always benign on your kidneys. Majority of the cases will never have microscopic hematuria or proteinuria, but some percentage will have hematuria, and some of that hematuria kids will have proteinuria. We really get concerned with this if this proteinuria is a nephrotic range. Okay, so if it is a nephrotic range proteinuria, those patients definitely need to be biopsied. Okay, even with a normal creatinine, because we know we want to see on histology level for those kids where we are in regards of, is it only acute, how extensive is it, is there any degree of chronicity, and then because the diagnosis will be IgA nephropathy on the biopsy with the IgA staining on immunofluorescent, but we want to know the extent of the disease to know how hard we need to have them with the immunosuppressant, because if we don't, they will progress into end-stage renal disease. HUS, again, remember HUS with the hematuria, there is two categories, the common one, the diarrhea positive, which you will see patients, and then which is the benign one. Okay, so I'll just go quickly the last couple of slides, I think. And then those patients, almost always, even if they require diarrhea positive HUS, even if they require dialysis, they come out of it, okay? But in atypical or diarrhea negative, which is atypical HUS, where you have a problem in your alternative complement pathway defect, there's several mutations in the complement, an alternative complement pathway defect, which cause it. Usually we suspect it in a younger child, even if there is diarrhea in it. So the younger the child is, coming with a picture of HUS, mean microangiopathic hemolytic anemia, thrombocytopenia, and renal failure. Even if there's diarrhea positive, those patients, we urge you to send complements. And if they are low, think of these patients having an atypical HUS, because their treatment of using eculizumab to block the complement activation, overactivation of the complement system, will be the treatment for those patients compared to just supportive treatment in an typical HUS child. I think my time is over. I'm sorry. So can I give 1 minute? One word about Alport. It's not always in boy. Okay, remember 20% are autosomal recessive and autosomal dominant, and they do worse in regards of their renal outcome. Okay, compared to even the X-linked. So the girls come with Alport, will do worse and will go into end-stage renal disease. Actually, right now I have a patient, we just started dialysis last Wednesday on, a girl who's 11-year-old. Those patients will have persistent microscopic hematuria. With time, they will have hearing loss. They are not born with it. They will develop it later. Send them for eye exam, looking for lentoconus. And there is always, almost always a positive family history on those patients. Benign familial is not too benign. Some patients, very small percentage of patients can also develop some renal impairment. But overall, let's say it's a benign course. It's an autosomal dominant. Always you will have one parent with hematuria. So screen the family, the parents for hematuria. I'm more than happy to share my slides as PDF to the people attending. So this is kind of a checklist. You don't need to remember every single one. You can have it as a handy to think of, will guide you toward, is it serious? Is it gonna go to something? Is it hematuria? Is it serious? What should they do? Okay. Again, this is a proposed workup of what you would do according to your history and examination. And that's it.